I work in most, we had the so-called Green Revolution, which prevented what people in the 50s and 60s were predicting was going to be worldwide famines. And we did it by increasing the quantity of food and dropping the cost. One of the ways we drop the cost is by elongating the supply chains, so that food that used to be trucked into the city from the gardens outside the city and the farms outside the city and eaten the next day or the next day or the next day is now in 60-day, 90-day, 100-day, 2-year supply chains. And the only way you can keep wheat in a supply chain that long is to process it. And the only way you can keep it, what you have to do to make it survive that long is take a lot of the good stuff out of it. So what's happening is we are growing food where the seeds are being developed to grow taller, to grow cheaper, to be drought resistant, but by the way, not to be more nutritious, because that hasn't been a metric. People haven't understood that, and there are trade-offs in that. And then when we process, we're processing for price and for quantity and for allow it to be stored in a big shed for a year in case there's a famine, as opposed to eat it quickly. And this is why these dates on the packages of food you buy are totally irrelevant. And you can eat that Twinkie 4 years from now, and it'll still be as bad as it was the day you bought it. Or 20. So number one, there's this industry, and it's not that they're bad people. It's that we gave them those metrics, and now we're asking that ship to turn around. On top of that, we've built a whole industry of convenience. At the time, we had a women's revolution. It isn't done yet. But one of the wonders of it was that it freed up women from growing the gardens and cooking meals and doing laundry all day, and allowed them to go do other things. So the idea that we are going to reverse that and send them back to gardening and back to cooking fresh food and so on, it ain't going to happen. So one of the things that happened is just as that was happening, that women were saying, no, I want something more with my life, the food industry stepped in and said, no problem, we'll take care of it. And we have TV dinners, and we have convenience food, and we have a restaurant industry. So let's just recognize what we're up against that's very, very, very powerful. And the reaction to Mayor Bloomberg's bit about the size of sodas in New York last year is kind of an indicative of how the public doesn't yet get this. Second comment is that it is insidious. I mean, this is addictive. Sugar is addictive. Salt is addictive. He was just talking about the lack of plasticity of the brain circuits here. There is real powerful body chemistry that occurs here that's very hard to turn around. So those of us who kind of who are smokers or lived with that, should understand the public policy parallels, the impacts, and so on. One that you may not be aware of is what we call epigenetics. What we're starting to see, particularly in the developing world, is that malnourishment changes people's genes. And so not only is the malnourished child of a malnourished mother more likely to have diabetes, type 2 diabetes early in life. We're seeing a lot of that. What we're seeing on top of that is that the children of that child are more likely to have diabetes, because it turns out that the malnutrition turns on genes in ways we don't yet fully understand. Final comment that I'd make is that this is really complicated. Nutrition is the thing that defies randomized controlled trials. It defies simple answers. It defies and yet, notice what we're trying to do. I think the problem here is the absence of vitamin D. So if we can fix vitamin D, then we'll solve depression. No, actually that's wrong. It's omega-3. So if you'll take fish oil pills, you'll be fine. No, you should have the Atkins diet. So, you know, we've got to be really careful as we address this, that we can take advantage of this of this and say, look, we're the behavioral health people. We understand the complexities of life. Getting a job is just as important as taking the depression pills. People are holistic. Let's look at this more broadly. That's what community mental health understands far better than others, the complexity of these things. But part of that, but we have to be true to that broader idea as we bring nutrition into the discussion. You folks are much more likely to be able to handle that kind of complexity, and groups like CRI are much more likely to be able to do the massive data analysis that will tell us how to help people in this field if we don't go down these siloed rabbit holes that kind of the pharmaceutical approach to malnutrition would ask us to do. Okay, that's my little soapbox at the beginning. We have a terrific panel this morning of people, none of whom I think would characterize themselves as nutrition experts. Indeed, though, they know an awful lot about nutrition and where it fits in this broader idea of well-being. We have a doctor, Troy, who is one of the few people in the world, in America, who's really actually studied the connections of well-being and nutrition and physical health. Sue Karber does for a living, tries to get this state to think more broadly about well-being and mental health. And if you haven't met the fellow in the middle, you need to meet him and know him well. I'm sure most of you know him, but Tom really thinks about how in a practical world of those of you who run operations, how do you incorporate this kind of new knowledge? With that simple introduction, I'm going to start with Troy, who's been looking at this, and ask him to open up with whatever he would like to add to the discussion.
Good morning. It's a pleasure to be here, and I want to thank April for inviting me to speak here. I agree with everything that was just previously said in the previous presentation, but it's a very complex issue. As a primary care physician, I think a lot of the problems with with most primary care physicians is that they haven't had the exposure to nutrition and dietary and preventative medicine. There's a small amount of that taught in medical school and not really taught in residency as well. So I think there's a lacking education on that, although they know, preventative and dietary and exercise is important, but they don't know how to push that to clinical sense. I did a 2-year fellowship in integrative medicine, and so I've learned a lot through that fellowship. Even knowing all this stuff, it's still very difficult in a primary care setting to be able to have the time, have the resources to motivate patients to change. And I think now I've joined a community mental health organization, and we're integrating primary care with psychiatric care. And I think that's going to be one of the key components to really trying to change how we deliver health care. It's been a great experience in that organization. We have peer support, which I think is going to be very helpful for getting people to change. So one of our first steps is to try to educate the peer support on healthy dietary changes and lifestyle, so they can communicate with their peers, because sometimes they have a little bit better way of communicating that with them. So I think that's one thing. We work with the psychiatrist and the primary care together, and I think that's going to help facilitate these changes. But again, it's a daunting task, and I think we need to educate primary care physicians in how to deliver this information, and also educate all the other staff in the primary care setting.
Sue Karber is head of wellness for the Tennessee Department of Mental Health, and so she is in a policy position to actually address these issues. Sue?
Yeah, Yeah, so my favorite thing is getting to play, actually. So I travel across the state. I work primarily with peer support centers and psych rehab centers. And what you were just talking about is what we've done. We've taught peer recovery specialists how to empower the people that they work with to start leading a little bit healthier lives. And we've done that through bringing lots of different programming in. Yesterday, Ben talked about a Stanford model. We use that model, the chronic disease self-management program, which is empowering people to take control of their health, their lives, being able to make decisions that just because you're told to do something, you can question that, being prepared, specific, trying to increase physical activity, trying to eat more fruits and vegetables, things like that. So working with people and really working with engagement and generating excitement around health and wellness. And it's been absolutely transformative, I think, what we've seen throughout the state. And we have partnered with CRI on this grant, and we've seen 86% of the items that we're measuring, we've seen a significantly positive change, which is just, it's phenomenal. And the things that we haven't been necessarily targeting, things like smoking, things like alcohol and drug use, we haven't seen a change in, but people are excited about trying to be healthy, about trying to be more active, and it's just been an amazing thing of watching peer specialists really work on engagement with other people and motivating them and teaching them some very, very simple skills that we're seeing just, again, just transformative results throughout the state.
I introduced him as Tom Capobianco. He is, of course, Jeff Capobianco, so I apologize for that. But Jeff, if you don't know him, has spent a lot of time working as a mentor, as a specialist, trying to help community mental health centers across the country adjust to the rapid changes within the industry. And then spends a good deal of time at the University of Michigan in a more academic setting. Jeff.
Thanks. I didn't even notice you called me Tom. I don't know what that means, but I guess I respond to Tom. So in preparation for this, I'm very privileged to be able to work with the now 100 grantees that are doing this hard work of integration, and talk with Deb Scharf, who, of course, you heard yesterday did the evaluation on roughly 50, and called up a bunch of the wellness programs to find out further, what do you guys do? Looked at the data Rand had collected around, quote, wellness programming, and it's a requirement of their grant that they implement wellness programming. So not surprisingly, over 90% had done this. Just being able to define wellness is tough, because people define it in lots of ways. So people had nutrition groups, they had walking groups, they had all these different things going on. And some of the take-homes are, after hearing that previous presentation, you can get pretty depressed, I think, and start to eat lots of fat, I guess. But there was some take-homes from what I heard from the field and what I'm seeing from the field and what I'm hearing up here, is that the fact we're in the field of behavioral health does put us in a good position to help people actually begin to change their health behavior. So when I talk to the sites, they're seeing a lot of value in peer involvement, which speaks to the fact, I don't know if any of you have read the book Change or Die by Alan Deutschman, great book. He talked about the medical community often using fear, facts, and force to get people to change their behavior. So they kind of scare them, you're going to die, here's some research, and by the way, I'm a doctor, did you see my degree, you should go change your behavior. And although that's not necessarily bad and that can contribute to health behavior change, the things that really get people to change their behavior are rewarding them, reinforcing them, refocusing on what they care about, basically motivational interviewing, repeating the message over and over again. And what we're hearing from sites is that if you can, make people aware of this idea of nutrition, there's lots of research around how the food pyramid was very confusing. Now there's the food plate. Michelle Obama's pushing that. I think the research will show that the food plate is pretty darn confusing too. So the message to consumers, the message to, I guess, anybody is really, what can you do that's simple, that is kind of silly or fun, because there's a lot of research around, you look at Kinnaman's research, or even Dan Earle's research around behavioral economics and what gets people to change, there's got to be some emotional component to it. So when working with consumers, what I'm hearing is they keep it really simple, the message, so reduce portion size. Just work on that. Go to McDonald's, but save half of it for tomorrow to save money. If you can do that, that'll be a positive thing. Eat low. You know, fish are lower than chickens, chickens are lower than pigs, pigs are lower than cows. You know, if you're eating giraffe, it's probably not helpful because they're really big. You know, silly, simple ways of thinking about managing intake of food can have a powerful impact, because the people we work with, and us included, I travel a lot, just trying to manage an airport is like a nightmare because all the food is just sugar-based, and I absolutely love sugar. So being able to manage, you know, as a consumer dealing with symptoms, dealing with poverty, being able just to manage their life, they need to have simple things that are kind of funny, so tying in that emotional component to the message around here's what you can do for your health is showing some promise to help folks begin to eat better and to begin to move the needle as it relates to their weight. And we have seen weight loss across the grantees. Not super significant, but it's trending in the right direction, which is good news.
They're two related, but not different things here. One is weight. And I don't think there's much question that being significantly overweight is a problem and creates a series of issues. But that is not the same as malnourishment. And we have tended to use as our indicator pounds or calories. And as the last speaker said, all calories are not created equal. So this idea of getting nourishment really, since we don't have good measures of nourishment, as I said yesterday, we're working on them. 5 years from now, we'll give you really cool stuff, and we'll get there. But for now, I think there's an issue of diversity. Eat less processed food, more whole grains, broader, that get away from anything in a box is probably not a good idea. So as I try to become kind of a nutrition Nazi since I started doing this two years ago, but as I try to do it in my own life, it's really hard to do. I mean, it's really hard. So doing something simple like buy the walls in the food store is probably the way to go at the beginning. So how do people running behavioral community mental health centers, they have some knowledge now, and they've been developing knowledge. So how do they turn that as part of their business model? Not just another good thing to do, but how could this become part of succeeding in a difficult time? Jeff?
Yeah, it's a complete shotgun approach, what I'm seeing from the field right now. From a policy standpoint and a financing standpoint, most wellness services can be covered using case management codes and billable services that they currently have in place. So most organizations are able to sustain some level of, quote, wellness type service delivery, but they're trying everything from smoothie clinics where, you know, you've got kale or spinach and fruit being blended up, and that brings people in to look at what are you blending, and they, you know, hand it out to consumers in the waiting room, to gardening, to nutrition classes, to cooking classes, to development of cookbooks. So people are trying really hard, but I don't think there's, you know, some evidence base or something that says, you know, do this, don't do that. And that's something that we need as a field to emerge around, and I think CRI could be helpful if we see that a center is trending with their BMIs are coming down. We want to reach out to them and say, hey, your data shows you guys are doing a great job on weight control. What are you doing? So others can learn from that would be very helpful. I was intrigued yesterday by Jeff Hammerbacher's mention around technology and whether the Nikes of the world are going to kind of take on this idea of mobile apps to help around exercise and nutrition, or if the healthcare industry is going to do it. And did some reading last night. It's a $9 billion industry right now, the mobile apps for helping people with, you know, exercise and nutrition and things like that. Is expected to be a $18 billion or $30 billion industry by 2018. So I think that's one thing, that if we can find apps that are fun and that are easy to use, if it's simple and it's fun, people are more likely to give it a try, when they're not being beat up by, you got to lose weight, you're a fat person, you need to become thin, and, taking the perspective that, hey, you're where you are right now, let's get you healthier. You're already healthy, let's make you healthier, that kind of messaging, and keeping it fun. If community mental health centers can do that, I think they'll cover a lot of ground as we develop an evidence base for, do it this way in particular.
Troy, at a slightly earlier stage of your career, you were trying to implement this kind of thing for a big bank who had decided that it was valuable for them to do. Is there a model in there someplace where, not an employer on its own, but where some of the folks here could go to major employers and develop the kind of thing that you were doing in San Antonio, I think.
Yeah, I think that's going to be one of the key components is taking our knowledge that we glean and trying to promote it to the large corporations because they're the ones that are really going to be able to affect a change because that's the employment and people want to continue in their employment there. And I worked with Chase Bank, and they have two large centers in San Antonio, about 3,000 each site. And they started off by trying to bring preventative health and wellness into those sites. And they started off with just a nurse doing some screening, but the screening really didn't lead to anywhere. They just got a number, and that was that. Then they decided to bring in myself, and we tried to do a lot of promotions to, so we took the screenings and then we discussed, with the employee, what this meant, and we came up with different scenarios on how they could improve on that. We worked with the kitchen staff at these facilities to try to steer away from the processed foods and try to bring in more healthy foods. They had contests on, they had developed a beautiful walking path, but it wasn't really utilized. So we came up with games and fun things to get people to, venture onto those walking paths contests, that kind of stuff. And that seemed to improve their motivation, of course. Chase Bank was to, to improve the health and bring down their healthcare costs, and also their hope was improved productivity from their employees, and I think that's a big push in this industry. My brother-in-law is also a family physician with the same fellowship training, and he's with HEB, which is a large in Texas. It's the largest grocery store. It's 78,000 employees across Texas, and they're doing the same thing. They're bringing in clinics there. They're doing cooking demonstrations, cooking classes. They're bringing nutrition, exercise. So I think the big businesses is going to be a key component for us as a community health center to get it together and really figure out how to do this and then bring it to them. And I think that can hopefully bubble up and provide a change in healthcare delivery.
Sue?
So in our state, there are funding mechanisms to incorporate wellness through peer support, through psych rehab, case management, things like that. But I really see the key being the leadership at the agencies. If the leadership at agencies are invested and embrace this concept, it kind of filters down. And I know our model is we utilize peer wellness coaches. And if their supervisors at the specific agencies are embracing this concept, it makes it a lot easier for the fun to come into that, of being very creative, of making eating more fruits and vegetables fun, trying different things, instead of just focusing on bringing in, a lot of agencies will get free donations of food, and what normally comes? Starbucks, processed foods, everything like that. And so, I think that there's a balance of, we've got a tight budget, we can't necessarily afford, number one, the money, but number two, the time as well. And are we enabling the people that we're working with, especially in programs where we're serving people all day and serving them meals and serving them snacks and having sodas available all the time of simple, again. And we use, instead of choosemyplate.gov, which is the plate, I really like Harvard School of Public Health, their plate model, because they advocate for no sugary beverages, which choosemyplate.gov does not. So increasing the amount of water, which is something simple. Increasing the amount of fruits and vegetables, fresh fruits and vegetables that you're eating, and not necessarily saying, okay, we're not going to have as many Snicker bars, but if you're eating more of the healthy stuff, you're going to automatically eat less of the unhealthy stuff. So again, very simple, but I mean, in our state, leadership has been absolutely key.
Great. Well, let's toss it open to the audience in the back there, sir.
So, as I listened to all this, I feel like part of this metaphor for a second, but I sort of envision these planes coming and dropping napalm everywhere, and we're kind of figuring out how we can take fire extinguishers and save the people on the ground. And I mean, the fact of the matter is that the napalm is there are billions of dollars being spent today convincing people that a healthy meal is fried chicken, mashed potatoes with gravy, and some biscuits. And I can go on that. And so as we try to convince people to stop, you know, to have healthy lifestyles, and we think of the implications in terms of diabetes, all kinds of cardiovascular issues, now depression, I feel like we're still missing the big picture on this. And you know, Debbie Tate's been a big advocate for addressing this bigger issue for a long time. With the smoking issue, when we think about when all the cigarette companies were advertising and convincing people that cool people, masculine people, feminine people, whatever, that the thing to do was to smoke, anybody that was around smoking cessation was just fighting an uphill battle that was no win. It wasn't until we could go, you can't advertise cigarettes. You can't advertise cigarettes that we began to have any kind of leverage in terms of turning that around. So, you know, I know even with our weight system, we've had some wonderful programs that are helping consumers choose more healthy lifestyles, but it just feels like it's incremental movement against an overwhelming wave of Madison Avenue. So anyway.
You know, I feel that way a lot. I agree with you. But having lived through the smoking changes from a regulatory point of view and from a personal point of view, I used to smoke 3 packs a day. You know, and remembering that I used to drive a car with 3 kids in the back, and I'd crack the window a little bit so my smoke would go out. You know, I mean, when I think about what I did to my kids, they remind me repeatedly. But we made enormous progress on smoking. I mean, we go back and look 30 years ago. Despite all of that, we made enormous progress. And I think when it happened was when the secondhand smoke studies started coming out. So it wasn't about you, it was about what you were doing to me or doing to my kids. But there was a tipping point where we started really winning that. This conversation about food and health and food and mental health and so on has really just started. There's been some experts out in the field looking at it, but the conversations I'm having with people now are radically different than they were 2 years ago, with health people. So I think there's hope here. The hope is to find the people whose businesses are affected by this. I mean, for the most part, you're in mental health. That means you have not been in nutrition. But here's a behavioral health event that your organization's hosting and nutrition's on the, I mean, that's different. So, and I'm seeing the same thing all over the world. So I think there's hope to it, but part of it is who are the allies? Who else needs to be in the conversation? And that's why the stuff about when J.P. Morgan is starting to get into this, that tells you something important. So I think the key issue is who are the allies we need to have, and what's the business model for you to really go after it? But,
and I know when we are doing trainings with staff around how to become care navigators, and we always talk about nutrition and this idea they have to be aware now of how to work with somebody around developing a wellness goal, which could include nutrition, should include nutrition. That some of the first things we're hearing from staff are, oh, if we're going to teach people about being healthy, we need to be healthy ourselves. So a lot of the staff are, because in our field I think we're pretty psychologically minded, they're looking back towards themselves as an organization, saying, well, what are we doing to help ourselves be healthy so that we can be sending the right message to consumers and to society? And it's this idea, because I think both Davids are right, that we are shooting arrows at a stone wall, it can feel like sometimes. But, if we're going to break through, it's this idea of awareness. And even studies around the fact that if you just take a picture of the food you eat with your cell phone, which is a silly, simple thing you can do, you will have gains around portion control, and over time you start to see people shifting their behavior towards eating healthier foods just due to awareness. So just creating awareness, helping people be more mindful of their behaviors has impact over time. And that's something anybody can do, even if you're struggling with executive functioning and have symptoms that really prevent you from producing complex plans. Just keeping things simple, silly, positive can have tremendous benefit, I think.
I'll give you an example. A year from now, you will not have a candy dish in the middle of this table.
Yeah.
True.
And
I was just gonna
we've
say-
actually seen that. I mean, with our initiative, we've started to affect conferences where consumers go, or just regular folks in the behavioral health field go. They're stopping having candy out at all the display booths out there, offering other things, and they're having healthy snacks in between, serving healthier lunches, not having soda available, having just water and maybe some other low-calorie beverage, things like that. But I also wanted to add on to that, there is, and we all know this through peer support, the amount of hope that one person can give another person to change behavior. So if just one person, you're affecting change with one person, everybody else around is going to see that and be able to give some hope and to create more of a domino effect. We've seen that just about in every center that we've worked in.
Yeah, I just want to add to that too as well. One of the other partners I think that are partners that need to be involved in this is the whole family. So if you're just working with the individual, but then they go home at night and the person cooking the meals wasn't part of that discussion, then we're losing out on that. So I think the whole family kind of as a unit needs to change as well. And then as Jess was mentioning, we have the same issue with, we hire peer support and they'll be out in front of the clinic smoking their cigarettes, and then, they'll be talking to one of their peers that is a consumer of ours, and they'll be smoking together. So, and we're, the health part, so we want to promote the healthy lifestyle, and so that's a challenge that we have as well.
Our experience with that is when you let the peers know that they are role models, that people are watching your behavior, they're not just listening to your words, they respond very well to that. And they may still smoke, but they're smoking behind the building where nobody can see.
There's a key issue here, which is, okay, so what do you do, what works? And that means what's the protocol, and how do we quantify it, how do we measure it? And that's something that I think that with some focus, the Knowledge Network can be really a powerful force to sort through all of the grow a backyard garden, do this, do that. There are some things that will come forward, as Jeff was saying, that we need to kind of coalesce around. A lot of people have been working in the nutrition field for a long time, asking the same question, Dave, you were saying, and they're delighted to have people like us come around and say, oh, what works, what doesn't work. Yes?
So why is it that the FDA for our country allows certain processed foods or chemicals that the global community or the FDA, in Europe or other parts of the world, I mean, you could do simple Google searches when you read a box of processed food and quickly find hits that suggest that there's a high probability for cancer-causing properties in certain ingredients, and that are strictly banned in other countries. So I tend to think it comes down to the almighty dollar and a lot of the stuff we've been discussing today, but.
Well, there's actually some real history behind it. If you go back to the FDA history, where it came from, Sinclair Lewis and some interesting gutsy people coming out of the Department of Agriculture. The chief scientists who started this in 1880, 1890, all their focus, and the FDA's focus, was will food poison you? Will food really harm, will you get sick from what you're eating? And so our whole regulatory structure is set up kind of what I call the organic model, which is don't put bad stuff in food, as opposed to put good stuff in food, or make food, don't take the good stuff out of food. So we have this whole don't poison us as opposed to don't malnourish us regulatory system. And if you go to the Department of Agriculture, you talk to, they don't think their job is nutrition for the most part. Their job is to feed America at a cheap price. So, but I think that's changing, and it's changing. I mean, the kind of silly arguments where our own government is not saying don't drink sodas. I mean, that kind of political thing. 5 years from now, we'll kind of laugh about that, I hope. One more question, and then we'll be done here. And all the way in the back.
From the PBHCI evaluation, which I think is really important, is that of all the outcomes that we were looking at, the physical health outcomes, the two that were hardest to move were weight and smoking. And so on the one hand, to hear the conversation about how, we've beaten smoking and we're doing better, 65% of the folks served in the PBHCI program are still current smokers. And despite all of the really creative and exciting interventions around wellness and nutrition and diet, weight didn't move. It didn't move. So I have mixed feelings about the right way to approach wellness services in a community behavioral health setting. On the one hand, I think having peers involved is really exciting because it builds momentum and it gets people engaged and excited. So, there's a real value there. And also, we know that when programs aren't evidence-based and implemented rigorously and with fidelity to particular, practices that do move the folks on the scale, we don't see outcomes. So while the momentum and excitement is there, I wonder, and this isn't data-based, but I wonder if it has to be a hybrid approach between peers and also people who really have the expertise to make sure that the program and participants are moving along in the right direction. I think it has to be top-down and bottom-up.
You have the last word. Thank you very much. Thank you to the panel.